Hi, everyone. We are back and we're doing part two of advanced care planning. AJ and I are going to be finishing up Five Wishes, the Five Wishes form. Last time we finished right around Wish 3, and now we are going to tackle Wish 4. Thank you, AJ, so much for being here again. Appreciate your
Of course.
presence. So Wish 4 really focuses on what the writer, the patient, the person of focus would like people to keep in mind in the way they treat them. And that can mean different things to different people, but I will just kind of give a very general um, statement sort of what that means from my perspective. Often people have really strong feelings about the way they want to be physically handled, the way they want a room to look, the way they want spirituality to come into their end of life or their um, uh, bereavement, their time at end of life. And so this kind of starts to shed some light into that, and you can get really specific. The form has a bunch of different thoughts and ideas, and the idea is that if you don't like one of them or if it doesn't mean very much to you, that you will cross them out. Often they can include things like whether you or not you would want a chaplain, rabbi, spiritual leader to be present, whether or not you would want prayer, for example, how you want to be called, um, and things like music. So it can be something really, really big that can be a little polarizing, like I want to be addressed by my nickname, or I want to be gendered properly. I want things that may trigger things in your community and your caregivers, or something as simple as I want to make sure that we're playing Chopin, or AC/DC in the background. Um, Other things that can come up is how many people in the room, who is okay to see you, and again, how you're handled physically as well. And so, AJ, for you, when you see this, what comes up for you, and any questions or thoughts that come up about this?
Sure. There's some things I'm curious about with this, and then there's definitely things that come up. Um, so I'll start with that. I think that, um, I have a very close-knit family, and, you know, at times we've kind of dipped in and out of various like religious faiths and practices. So I guess I'm not really sure. Um, of the what the role would be of like a clergy or chaplain, but I guess I'm open to it. I just don't, I don't foresee people coming and like having a prayer vigil, but also um I wouldn't mind if someone came in. So I'm kind of flexible on that, I guess, but I can see how some folks and families might have very specific like wants or dis dislikes regarding that. Yeah.
Yeah, I think you're bringing up a really great um, point, which is that sometimes we do things or we allow things because we know that it helps hold space or comfort or begin bereavement in the right way for people. And so I think that's a really great thing to think about. I think what I would kind of reflect back on to you is, if this is not a huge deal to you, but you think it may cause some decision paralysis or will cause, well, grandma's a Buddhist and mom is a born again, and I don't want there to be friction, then this is part of the conversation. all is welcome might be fine. All is
Yeah.
welcome, and I want everybody to allow space for the Buddhist chanting to happen, as well as whatever prayer or process needs to happen for the born again folks. Um, it is important to me that this is harmonious. I think that's a fair thing to say. If we know that there's going to be a lot of tension, it's perfectly fine to say, while I welcome your um, spiritual process to happen, it would be most helpful for us to stay together and cohesive to have that happen privately for you. I think that's a fair thing
Sure.
to think about. Is that helpful?
Yeah, for sure. And I think that one of the things I thought of with this is that, I would like to have people around me and, talking with each other and like not afraid to share things that may come up, whether it's happy or sad or anywhere in between. Um, I think in my experience, people can kind of tend to clam up or not know what to say. But yeah, it'd be important for me to know that people can come and just be themselves. And like, I imagine it might be really helpful and healing for me and probably for them too, just to be able to spend time together and, just let whatever needs to happen happen. I'm
Yeah.
definitely okay with that. One of the questions that I had was like about physical treatment. Currently, I kind of vary in terms of, whether I want physical contact or not. So I'm just curious, like, does that change a lot in your experience for people who are, near death? Like, is it common for that kind of preference to change? Like, some people really like physical um touch and some people really don't. I'm just curious if there's, when like discomfort may arise, do people
Yeah.
tend to want to be left alone more or what?
Mhm. So by and large, I think that people stay pretty consistent. Um, and I think as a clinician, there's all these tools that we have to say, when somebody's no longer able to express themselves, these are the things to look out for. We actually are able to tell caregivers, trust your instinct. You have held your partner, your child, your significant other, your family member's hand through discomfort, and they shooed you away when they weren't vibing it. And um, you know that energy, so trust that instinct. We also say we have these tools sometimes when we see certain physical exam findings, like furrowing of the brow or, breathing patterns change. That tells us that things are going one way or the other. Um, and and so there's some objective things that clinicians can help, and so a hospice team or an inpatient team could help guide. It seems like that's too many blankets. Let's just take a step back, or there's some sweating. Were they usually a cold person or a hot? Do they run cold? We can trial and error it, but always allowing the caregiver to sort of trust that instinct is important, and I think there's a lot that we still don't know about what happens in that space. So I want to say that we have tools, and people stay pretty consistent. And if I've learned anything in my 20 plus years of doing this work, is that um, I'm often proven wrong, and that's why you want to make sure that you're using all those tools that are available.
Sure. Yeah, that makes sense. And I really like this wish number four. Like, it has a wide variety of different preferences that I've had a chance to look through and think about. Everything from that physical touch to just the surroundings and the environment. I have a friend who ended up with like, a favorite shawl that she wanted with her and like some maybe rocks or plants or different things that she had. So yeah, I have some Spotify playlists I've been working on and so yeah, it's really nice to think about kind of
Yeah.
your preferences and what might make you more comfortable.
Totally. It also gives people a job, right? So now person
Mm,
X will be the DJ, right? Person Y will be like, AJ made it clear that they wanted communication, and I'll be the reminder. I'll be the one that says, um, remember when, and that'll kind of get a conversation started. I will give an anecdote of a patient who really wanted to have a party. They wanted that day to be a party. And they were from a culture where music was very festive and very kind of drummy, and it was really interesting because there was a lot of crying and a lot of dance crying, and it worked. It worked really well, and people knew what their job was, and they were both holding the grief and celebration of life together, and it was um, really beautiful. But there was a conversation had, so there was no awkwardness about holding both things
Hmm.
because this was the mandate. Um, and so that was really special to be a witness to. Um, and again, a lot of times people will be able to share what makes sense, and so um, this is this is if you're unable to really speak to wishes, but a lot of times people are able to still speak to what makes the most sense for them. Um, any other thoughts, questions, anything else that comes up that you think we should think about?
I think we've done a good job on this one. It really gave me a lot of things to think about. Yeah.
Awesome. I'm glad. And so Wish 5 really focuses on what I want my loved ones to know, right? So it's, again, really big topic. What does it mean? It's going to be unique for everybody. If we look at the form, it gives some very specific examples. And again, when you're doing this, you can write your own. Um, you can cross things out if they don't make sense for you. But they range from things that speak to, I want my loved ones to know how much I love them. I want them to know that I forgive and whoever or all of them, that there's forgiveness at this stage. I One that really resonates with me, and I really kind of like to spend time with patients about, is to touch on this one prior to having to ask for the 5 wishes to be enacted. And that's, I want my loved ones to know that I'd love for them to respect my wishes even if they don't agree with them. That's a really big and important one. And when people see it in writing, it's really, really helpful to folks who are having a tough time letting go, or a tough time with decisions that don't align with their values or with their emotions. Um, a couple of other ones are very practical, like, do I want to be cremated? Do I want to be buried? I want this kind of ceremony or memorial. Um, and some are more sort of ideas, more abstract. I want to be remembered a certain way. Um, those things are um, pretty powerful and really help, I think, both with the practical aspects of end of life, but also with the bereavement process. Thoughts here,
Yeah.
AJ?
Yeah. I mean, this is a pretty heavy one, just in terms of um, taking a whole life's worth of memories and dynamics in the family and all that stuff. So I guess I'm curious, um, how to talk about this one with family kind of before it's needed and before, we get to this point. Um, yeah, just because it is such a heavy, to me, it feels like such a heavy thing, um, to think about what I wish to be forgiven for, or, what my family and friends and others might feel they need forgiveness for. Like, I know for me, that's the one that's kind of sticking the most. So yeah, I'm just curious how you've
Yeah,
um, counseled others about that.
yeah. Um, so I'll pull from I'm going to pull from the therapist that I have engaged with, which is whenever something gives you a feeling and a pause, like sit with it for a little bit. And it's not about the act, it's about like what it what comes up for you. Um, and so I think in general, do we feel um, is there, shame, or is there fear of rehashing things that were hard and that you've moved past? Is there from their end, is there fear? Is it there fear for you about what if I get really angry again at them for X, Y, and Z? What if we don't resolve it? What if it feels like empty words? Um, I think sitting with that and just saying, like, am I going to be okay with whatever the outcome is? If we do engage in this conversation, um, I think it's important. I think it's also important to know, your audience really well. So if there's some hesitation or some pause and you feel like maybe this paper says that, but maybe this isn't the right thing for us, then really thinking about, is there an alternative, or um, am I okay with with the unknown? That this may go one way or the other, I think is really important. Some families are really big about the elephant in the room or the elephants in the room, the stuff in the closet that just kind of comes out, and you can still hold those two tensions of like, oh my God, we really need to be close right now. And also I want to strangle you because you were such a pain in the butt when you were like 15 or whatever it is. Um, and some are not. And some are not. And some folks feel like sometimes things are better left unsaid and actions speak louder than words. Um, and so I really think when I'm reading these things, sometimes they can be so suggestive and they may or may not be. And I love Five Wishes. So take this with that in mind, is that sometimes things are super culturally um, sensitive, right? And about based culture, where you sit on the birth order, your family structure, um, it may not always align really well. But if the forgiveness thing is giving you is making something bubble up, I would sit with that for a little bit.
Yeah, for sure. I think it's more that it's not something that normally comes up in conversation when we're hanging out as a family. So, but I think it's important for me to be able to not have this be like a surprise, you
Mm,
know, when we come to it. Yeah, that's what more what
yeah,
I was thinking. But I like what
yeah,
you said about this being a little bit of a um, I kind of like more very it's very specific kind of in these bullet points, like I wish for my family and friends to know that I do not fear death. Well, like I fear death a little bit, but I'm also okay with the unknown. So it's there's a lot of nuance I think that people can take with this, but I feel like it's a really good starting point
yeah,
to like
yeah,
go through some common statements that people have said to kind of make their death as good or growth oriented as possible, I guess.
yeah. Yeah, and I think that that's a fantastic way to look at it. Um, it's about legacy, right? Is this event, will you live on with your family for generations and then generations, and there's so much beauty in that, and this feeds into that a lot, but it also helps with the immediate bereavement um, uh, after you die, and so I think really what makes sense, yesterday versus a year from now may vary. And so really just temp checking where everybody's at. I think it's really important. And to your point about, hey, we're going to talk about forgiveness today, is kind of intense. I think much like when we talk about, hey, these are the treatment options and this is what I'm opting for, um, giving sort of what we call in palliative care a warning shot is really helpful. So sending a group text and say, listen, for Thanksgiving, I'd love to take 15 minutes to talk a little bit about X. I'm happy to answer any questions prior to us talking. If you don't want to be the part of the conversation, let me know ASAP, but I really would value that. And sort of disarming people with either humor or just like repetition, giving a heads up, giving a reminder, sending a little Google Doc or a little note with what you want to talk about and why it means a lot to you, and always giving people a way out, I think is really
Yeah.
important.
Yeah. I appreciate that. That's really nice way to do it and think about it. So makes sense.
Awesome. Awesome. Um, people will probably, especially if they are able to plan for their end of their life, meaning what happens after their body, uh, after they die and their body will be managed, whether it's a burial or a cremation. There's a lot of like practical planning that happens. I would say that this is sort of the beginning of that planning. So I want to be cremated, and then you let people sit with that. And then we do the actual planning, which is we secure a company or a group that will do this for you. You can do research. Finances are important. So, what are the funds? How does this get managed? If families are working with a hospice will do all the work of, okay, just give us the name and we'll make arrangements. Um, those things can happen, but I wouldn't want the burial and cremation to end there. If you have the opportunity to plan ahead, I think that's really important because there's so much happening that as
Yeah.
many people that are involved in planning and sort of aware of what the next steps are is really important. And delegation is really important here as well.
Yeah.
You have a lot of people that will want to be helpful. You'll have a lot of people that will obviously be in profound grief. If people have jobs, it makes it easier for them. Oh, I'm the one that's supposed to focus on X. I'm focusing on Z, Y, whatever.
Right.
Everybody has a role.
Yeah, that feels um really useful and helpful to give people jobs. Um yeah, it just seems like it would not only help to direct people's, emotion or sense of grief and everything, but also it could help like spark conversations and really pay it forward a bit and have that happen for others too.
Yeah.
I think that makes a lot of sense. I was curious about funeral services.
Mhm.
I was talking with my father recently, and he said he wasn't sure if he wanted to have a funeral. And we're still talking about what he means by that, but I was just curious, is that um, yeah, how much variation is there is in terms of funeral services, memorial services? I think he was more thinking of like a celebration rather than a funeral service.
Yeah, great question. And yeah, it can 100% vary. You can make whatever arrangements. If a burial is what you're seeking, um, there can be sort of the kind of more Christian sort of, or Judeo-Christian, there's a viewing of the body, a wake or a viewing of the body, depending on your religious belief, where people gather. And that definitely has a spiritual kind of connection piece to it. There are folks who just want to be buried and then have a party, and so arrangements can be made for all the appropriate steps that have to happen to occur, but then in terms of whether there's a wake or not, there's variability there. um, there's also this idea sometimes that people are allowed to, we want to bury the body or cremate and be given the remains, and we want to just allow the grief to kind of descend on us, and we may just have a little small gathering, have people over, and then we celebrate life down the line. Um, Sometimes people, I know this sounds really maybe harsh, but death is not convenient for people's schedule, right? And so really, if gathering is so important, and having the big party is important, then finding a time where it makes the most sense. I do know folks that will wait the year to gather the folks that mean something to them, or wait till the summer if they had a bunch of grandchildren that were off in college and but they still want to make that happen. Definitely so many ways of doing it. I know of folks who have made trips driving across the United States to spread ashes or spread um, little origami figurines that the patient had made, and they wanted to leave them in national parks or different places in the US. And so it became about putting the resources into funding the road trip rather than the big funeral. They save some money in that by cremating. And so
Yeah.
there's different ways, but of course we want to make sure that it aligns with the spiritual piece, it aligns with the finances, it aligns with people's schedules. Um, there is no one way of um, managing end of life, I think, is the big takeaway.
Yeah, makes sense. What about um, you know, following, somebody's body dying? Um, in my experience, it feels like there's a bit of a rush to then, call the funeral home and all this stuff. But is it okay to like have the body remain, if I or whatever whoever's at home like remain there for some time, and like what does that look like? Is there like anything you need to do or know about that?
Yeah, that is such a good question. I'm so glad you brought it up. Um, Couple of things. So, we can make arrangements. I think it is for many people, seeing the body is important, and that physical, like, this loved one has died is really important. There is a lot of cultural uh, ceremonies that happen that are meant to remind those that live that they're no longer here. Um, and YouTube is full of them. Um, why do we do that? Not to torture those that remain, but rather because closure from that perspective is really important. So I love that you brought that up, because that then people can come and be with the the body and start that process. So when somebody dies, their body will eventually start to decay like everything else. And so we definitely want to be mindful of time as being um, not our friend. But if we plan ahead, we can do things like get some dry ice, put it around the body to keep the body cool, and do so in a way that is still inviting, right? It's still, there's, not like, why are there all these bags of ice around you? You want to put them under the body, etc. Um, and that can allow for more time for the body to remain in the home or in the wherever it is that the death happens. You can plan that ahead, and there's funeral homes that will provide that for you ahead of time, and you can also have it. I don't know if Amazon, but dry ice services are available if you're doing something where cost is an issue or the like. Um, and even that has some limits. So we're saying this would extend by hours, but I wouldn't say that. I think after days, then it could be a little bit more difficult, and you might need like more expert support in like making sure that we're not getting into a dangerous uh, not dangerous state, but like uncomfortable state where we're worried about odor or about changes in color, etc. It is important for people to know and understand that the body will start to look different.
Hmm.
Blood is no longer circulating, and so the skin color may look different. The blood starts to kind of settle, and so um, a heads up about that is important. Using blankets where appropriate is important, but allowing people to hold hands, etc., is important. Giving people a little bit of a heads up that stiffness may set in, and so just keeping that in mind is important. Um, and all those things are easily researchable, or we can ask them in real time. Obviously, I'm saying some of them right now, but I think preparation is important in this case, both emotionally about what you're going to see, but also about like how do we prepare blankets and ice and all these things. I think is really really helpful. And then to say
Yeah.
when's our cutoff? When do we feel like who's going to ask the question? Who's going to um, pull the lever and say, okay, it's time to call and have the body. Um, Removed from the home or the space. If it happens in a hospital, there's less negotiation available because obviously rooms need to be made available for other patients. And with a physical hospice, sometimes that can also be the case in the home. There's much more flexibility, obviously. Um, does that answer the question?
Yeah, definitely. I guess the only other related question with that is, would it be helpful to, engage with some sort of professional, whether it's the funeral home or the, medical provider before
Yeah,
that, just so they're aware, or
yeah,
is there
definitely.
anything legally that you need to do, or
I don't
is that pretty much it?
No, I think there's nothing really legally that needs to happen, of course, in order for the body to be released. There is a process of identifying and then calling the death and having a
Okay.
time of death recorded by a clinician. A hospice would very well be able to do that. It would just be like, hey, if and when this happens, sorry, I see I'm always I want to call that
Yeah.
out, but I said if. Um, I am human and I also engage in thinking that is sometimes, um, I'll say magical, right? We're talking about a dying person. When the person dies, we would like there to we would like to remain with the body for as long as possible within the parameters that you have or that are biological, right? So is it okay if we hang out for 6 hours and just make sure that we have these things available? Or somebody's flying in, can we give some time for that person to come in and how do we buy some time? And so I would plan ahead. And it would be either the funeral home you're using, the hospice can be really helpful, um, and all the other services, this can be planned ahead with them. Even if they say, we don't do that, but you guys can do what you want, we'll come tomorrow, then you can have a plan. You can say, okay, let's buy a ton of dry ice. Let's tap into the resources that we have. There's a ton of stuff online, information about this, so that's super helpful. To gather that information
Cool.
if needed.
Thank you.
Hmm. Totally. Awesome. More thoughts about Wish 5?
I think we pretty much covered it from the things that I've been thinking about.
Okay. Awesome. So important things about 5 wishes and advanced care plans in general are that every state has their own rules about which paperwork they're allowed to use and to how witnessing needs to happen if you need a notary or something of that nature. The document gives you that information. So 5 Wishes itself will give you that information if you refer to the requirements page. That's one thing. The majority of states do 5 wishes or allow 5 wishes, but if your state doesn't, there's a ton of forms out there that are helpful. Um, and states themselves have advanced care plan documentation. If you just put North Carolina advanced care plan um, or healthcare proxy, all those things are available and usually in PDF form that you can download. And so that's really important. Once that's finished and all the witnessing and all the signage has occurred, you want to make sure that all the appropriate people in your life have either access to the document or know where it is located. Um, this is important because if your healthcare proxy, the person you have assigned as your voice, if you're unable to make medical decisions for yourself, needs to be able to show that document in order to be able to make a decision for you that it's readily available for them. And that is it about 5 wishes and advanced care planning in general. Anything else about that we should discuss, AJ?
I think we pretty much covered it.
Okay, awesome. The other thing we wanted to talk about today was talking about POLST, MOST, or MOLST. I just said a bunch of acronyms. I'll dive into that in a second. But the DC form, we're choosing DC because of geographic preference for AJ. Every state has its own form. And what is this? These, whereas an advanced care plan gives direction, that then the patient, healthcare proxy, and the doctors can use to help guide what decisions are made from a medical standpoint. A MOST, which is medical orders of scope of treatment, MOLST, medical orders of life-sustaining treatment, or POLST, physician orders of life-sustaining treatment. There's different names in different states. These are actual orders that in real time can be applied. And so that we don't need to have a discussion, we actually have an order in hand. When is a 5 wishes advanced care planning ideal versus a POLST, MOST, MOLST? Advanced care plan, anyone who's over 18 or anybody who has a chronic illness should have, in general. The older and the more diagnosis you have, the more important it is to have an advanced care plan. We start getting into MOLST, POLST, or MOST when we are suffering from a serious illness, a chronic illness, where we will be possibly interacting with the healthcare system a bit, or within a year of this form being filled out, or if our prognosis or we are thought to be declining or close to the end of our life within a year. There are people with chronic illness that do this way in advance because they have such strong feelings about this is what I want the doctors to do. But in general, if you're trying to figure out which one should I do, that's usually the differentiation. You know, I am going to be in and out of the hospital a lot. If something happens, I really want people to have orders available. And so they vary per state. The language varies slightly, but they are broken up into different sections, usually A, B, C, D. And the top will have the demographics of the person. And then it really dives into very specific things right away. Part A usually talks about whether or not you would want to be resuscitated in the case of your heart stopping or you dying. Would you want to be resuscitated? The options are that whether, I do want CPR, cardiopulmonary resuscitation, which is a medical procedure in which we do many things to the body, including chest compressions, give adrenaline shots and other chemicals to restart the electrical impulses in the heart. And as we're doing CPR, we're also doing as best as we can to simulate the heart pumping to see if we can resuscitate the person and bring them back to life. This is a very you either do it or you don't, right? You either allow a natural death, saying you do not want to be resuscitated. When my heart stops and I die, I want to die naturally. I want that to be my time of death. And there's the other option, which is I want to have resuscitation attempted. CPR was devised for folks who had a high chance of surviving, but they had a heart attack. That's when this all came about. It has now morphed to something that we provide to everybody, whether or not we believe as clinicians that there would be a benefit for for this procedure to happen. What do I mean by a benefit? From my perspective, and generally thinking about it from a clinical perspective, that means that doing this procedure would bring you back to where you were or better. Usually that's why we want to do procedures. CPR in general doesn't do that, right? And especially in people who have a serious illness. It makes the news often when it does, but it's not a procedure that has a lot of success. That's important to know because we offer it. And usually patients believe that when somebody's offering me something, they're offering it because it's going to be of a benefit to me. Life, being alive, for many people will be enough of a benefit. The follow-up questions, I think, are important. Alive how? And those are the things that in chronic illness and serious illness are not so easy and often are not the way we visualize them or we see them on TV. Thoughts about that? Questions about that, AJ?
Um, well, I think you've explained it really well, Claritza. I think that in my understanding, CPR is a very dramatic and um, invasive kind of procedure that would happen. I mean, personally, I've decided that I would prefer to allow natural death and not have CPR. Um, and that's based on my own beliefs and kind of just imagining what that could be like for me. Like you said, it's not something that usually like is super successful. And I have a strong preference for my own personal comfort. And I guess I'm afraid that if I were to have CPR done on me, then, I could end up with various injuries or, more kind of life-sustaining measures than I want at this point. Is kind of my thinking on it. But I think you explained it really well. Yeah.
Thank you. It's really important to one of the things you've done that's fantastic is you've asked a follow-up. What does that look like for me, right? And so again, the TV and sort of media gives us a sense that CPR is just this magic bullet that kind of like, hey, I'm back. And thank goodness that happened. That was very heroic, and it is very successful in many cases. In people with serious illness, such as neurological illnesses, cancers, heart failure, things that are debilitating and cause organ systems to decline and may cause disability, these is not always as successful. And often people who are resuscitated often require medical equipment to keep them alive. And that might make a whole lot of sense for some people. But I think the important thing is to ask the follow-up questions. What would it look like for me after CPR if I was resuscitated? I think those are really important questions that we need to be able to ask our clinicians, and the clinicians have the knowledge to answer them. And as I said before, I've been doing this for a minute. I can give you a bunch of numbers, and I think you have to make the decision that makes the most sense for you. And so you may get a clinician saying, well, the majority of folks this, majority of folks that. It's never going to be an absolute because humans are not, there's no binary there, like everybody's unique. And so just make sure you are ready to hear a lean towards, an answer that may not be like a slam dunk, you are going to end up on machines. It'll probably be something like the majority of folks with a stage 4 cancer who undergo CPR and survive will live the rest of their life in an institution, likely a hospital. That's kind
Right.
of more what you'll hear.
Yeah.
Okay. Anything else there? Let's move on to medical interventions.
Sure.
All right. Again, every state is different. DC looks at Part B, medical interventions, and it gives very specific examples. What does that mean? Medical interventions are broken into three big buckets, and they are if the person has a pulse and they're breathing, how do they want their treatment at high level? They're folks who want full treatment. The primary goal is to stay alive, and that means with anything and everything that is offered to them from a medical standpoint. And that could include having an intubation, which is you have an endotracheal tube, which is a tube about this big, maybe slightly bigger, slightly smaller, depending on your size, that goes into your mouth, down your throat, and sits just at the branching of the trachea to help air, oxygen go into your lungs. That then is attached to a ventilator, which is a machine that does the breathing for you. That is what intubation would entail. Advanced airway interventions are different things that we can do, whether it's putting a tube into your nose, putting a different kind of tube into your throat to aid in your breathing. Mechanical ventilation is that attaching these tubings to a ventilator, which would be pumping air into your lungs because you're unable to breathe on your own. Cardioversion would be different electrical currents that would be provided and given to your heart, whether it's shocking to restart the heart or different interventions to kind of get the heart to move to beat in a certain way that is compatible with you being alive. Usually these folks who get full treatment end up in the intensive care unit, which is very controlled space where usually people are not awake because the interventions that we're engaging in are really, really intense and uncomfortable. And so if somebody is alive and we are having to have all this machinery on them, we would probably sedate the person aggressively in order for them to not be in a state of awareness. Selective treatment is sort of a middle of the road approach where the goal of treatment is we want to make sure that we're treating medical conditions as much as possible. And at the same time, we also don't want to be so aggressive that it becomes burdensome. And so that can mean less invasive airway treatments like medicine treatments like BiPAP or CPAP, where if you're having difficulty breathing, you're having uh, help with a breathing machine that kind of is pushing air into your body, but you're still awake. And it's not the most comfortable thing in the world, but the mask sits on your face rather than a tube into your body. You would get IV medication, antibiotics, other treatments, but we would say, you know what, let's not intubate because that would be too burdensome. And we kind of want to avoid the ICU as much as possible. And there's some flexibility there, but we want to avoid it as much as we can. And so we're doing a lot, but we're really thinking about comfort here. And then there's comfort focused treatment, where the primary goal is I want you to do everything possible to make sure that I'm as comfortable as possible for as long as possible. I really want to make sure that we look at it that way. So much of making these decisions is it's about what I'm not going to get. I'm not going to get CPR. And the reality is that you're going to get a bunch of stuff. You're just going to get stuff that's helpful based on what you want. And if comfort's what you want, then you can get a ton of treatment, but the focus is slightly different. And so here we're relieving pain, we're relieving suffering with medications and manual treatments and manipulations that we can do, really focusing on comfort. So patient is uncomfortable and they can't breathe. We're not going to walk away. We're going to do everything in our power to make sure that they're breathing as comfortably as possible. So we have a ton of wonderful medications that help us do that. And there's manipulations that we can do to help somebody feel comfortable from a physical standpoint, right? The way we hold them, the way we suction them, and make sure that there's nothing obstructing their airway. Usually these folks prefer not to be transferred to the hospital. There's a preference, and if we ever need to go to the hospital, of course, hospital is always available. There's no like absolute you can't go. Um, but you would be able to gauge and determine what makes the most sense if you were in a situation like that. If you look at the bottom, there's some additional orders that are open and it would be handwritten. And you can say things about, if somebody's on dialysis and they want to say, if X happens, then I want Y to happen. Or I definitely don't want to be on dialysis, or I definitely don't want to get antibiotics. People may have had experiences with different things and they want to make sure that that's avoided at all costs. You can write that there.
Sure.
Thoughts and questions here?
Sure. I mean, this is a lot to think about. I kept having to remind myself as you were talking that this is really for situations where I'm unable to make these decisions and I'm in like a very serious state, and it's here to guide the people who are responding to me being in that probably somewhat suddenly serious state. Is that a correct kind of interpretation of where we are here?
Yeah, absolutely.
Right. I think also I forget if you mentioned this, you probably did, but the the steps in part B were like building on each other. So if you say like the least amount of treatment is the comfort focused treatment, then the ones that are listed above that like include the ones below it. So it's not like you're choosing to forego comfort if you want more treatment.
Right. And so that's a really great point. So a couple of things. So I want to just push back a little bit on less treatment because I want to make sure that people walk away from this knowing that um, they're they're saying less treatment that may be burdensome, but that they're going to get a ton of treatment, right? And
Yeah.
I think I think it's important for people to know that we're thinking about this from the standpoint of yes, we want comfort, right? We want somebody seeking the most aggressive treatment to be comfortable. Sometimes that's hard to do, right? When you're getting chemo, you get anti-nausea medication, you get pain medication, you get told this is going to be a doozy, prepare mentally, meditate, do all those things. And even with all that preparation, chemo's a bear. It is no joke, right? And so that's coming from that standpoint. There are people who will say that's fine, right? And so, I think it's important for that to be noted that we think pain, being dissociated from reality, having a tube in your throat, all those things are in the majority of for the majority of people not comfortable. And but we're still going to sedate you, we're still going to do everything in our power to keep you as comfortable as possible for as long as possible. I think the key thing is that in the ideal setting for a majority of people, that comfort means being able to be interactive, do the things that they like, not be in a hospital setting. And also that the treatment is life affirming and helpful. And often as chronic illness progresses, we have a ton of available treatments, but they
Mhm.
don't do a whole heck of a lot for quality of life and for making the most of your time. It'll give you
Yeah.
time. It may not be the most of your time. And for some people, what do you mean by that? Well, for the majority of folks, just a heart beating isn't the most of my time. It means interacting with those I love. It means to be able to, go to my garden or see the water or like read a book or just take my own breath. Um, those things that's kind of the way I want people to think about it. Um, and the problem is with language, there's some limitations, but um, the idea is we're always going to try and make sure you're comfortable. It's just that the more poking, prodding, durable medical equipment, the less we're able to guarantee that.
Okay.
Make sense?
Yeah, for sure. I think the other question I have, if we have time, is regarding the medically assisted nutrition.
Uh-huh.
Um,
Yeah.
I guess I'm unclear on um how that maybe could help, or if it would be kind of a prolongation of suffering if someone is already, at the end of their life. So yeah, would you mind to talk about that a little bit?
100%. So that is section C. It really, we're getting down to more specifics on medical treatment preference. And again, depending on your state, this will general follow the same pattern, but it will be slightly different and things maybe move slightly, but all the content will be there. DC looks at medically assisted nutrition. Other states will just say artificial nutrition because that's what it is. It's not sort of the way in which we nurture our bodies naturally. Um, the options are I do not want medical assisted nutrition by a tube. Usually, a tube would be a tube that goes either into your nose or your mouth, and it's moved down to the stomach, the food pipe, the esophagus. Um, and then you get fed, and a machine kind of like pushes this slurry of a liquid nutrition that's not perfect, but it gets a lot of calories in there. Then you can do a trial of this medically assisted nutrition, or I want long-term assisted nutrition by a tube, which would then, this would be temporary. The tube in the nose or the mouth would be temporary. And for long-term nutrition, we would likely put a tube into the stomach through the skin and or through to the small intestine, which would be slightly off, kind of more onto the center, not over the stomach, but over the small intestine area. When does this make sense? It's important to understand that a dying body does not benefit from nutrition. When a body is dying, it takes so much energy to digest food that the body uh, is really focusing its energy on brain, heart, lungs. It really slows down the gut when it is trying to shift all its energy to these more vital organs. Of course, they're all vital, but you know what I mean. And so what we see often in folks who are dying is that their hunger goes away because Mother Nature kindly decided, let's make sure that the dying process isn't an uncomfortable one. And so you'll notice in a lot of folks who are at end of life, they're not as hungry, or they'll have waves of hunger and loss of appetite. Uh, and so who benefits from this? Folks who are still really active and are able to engage in activities of daily living, like walking and dressing themselves and playing chess and that just aren't able to swallow because there's a tumor or something obstructing, or they have a disease where the nerves are not coordinating the swallowing process well. Those people can benefit from bypassing the throat and going straight to the stomach. But by and large, folks who are debilitated and are dying will not benefit from it. And we actually have some data to say that it actually can prolong the dying process because you're giving just enough nutrition to keep things going, but you're not doing anything to fix the dementia or to fix the cancer that is ravaging their bodies. I think in general, it is really reasonable to talk to the providers, to the doctors, and say, what's is this possible? If yes, then what are the risks and what are the benefits? And how does this help my diagnosis? How does this help my cancer? How does this help my loved one's dementia? How does this help my debilitating disease? The key thing that people need to also understand is that we never stop attempting to feed, right? Often people will say, well, what if grandma gets hungry? Well, we always want to offer and encourage gentle spoon feeding and really following patients' cues. We all know that feeling when we're starving or when we're in the subway and it's really hot and we're really thirsty, and we would never want somebody we love to have that. And so we always want to offer, and there's different ways and tools that we can use in somebody who's bedbound to check in on that. Um, and there's ways to do it as safely as possible. And we always follow the patient's cues. I've had patients who, just as an anecdote, we had a lovely lady who had really advanced dementia, had lost a ton of weight and just couldn't swallow, and had some testing to um to prove it. And we're doing spoon feeding, and at some point she just stopped. And family was very concerned, and we said, what does she love? She loves vanilla milkshakes. And there's some concerns about, sucking, from a straw because of the what it does and the mechanics of that. But as a group, we decided, you know what, it is important for them to know that grandma and mom is no longer interested in drinking, or maybe she wants to drink, and we got her a milkshake, and she smelled it and put that straw in her mouth and just went to town and had a great time. And we sat her up, and yeah, there was some a little bit of coughing, and a little bit of like, let's slow down, but she loved it. And so there was some risks, there were some benefits, and we just kept checking in. And at some point, she stopped. She no longer, there was milkshakes and all the stuff that we knew she adored. And she just gave us a cue, like, we're done here. And so I think there's ways, as we're in these situations where we don't know kind of where we're at, where we can assess. But in terms of the medically assisted nutrition, there's some limitations to the benefit there. When it comes to like, how is that going to impact and improve and um, make my cancer better, or make my neurologic process better? There's some
Yeah.
limitations there, obviously.
Yeah, that makes sense.
When we talk about antibiotics are another thing that you can opt to say use them or don't use them. Um, you know, Infections at end of life often are not particularly very symptom inducing. Sometimes a UTI, a urinary tract infection, can be uncomfortable. Um, but by and large, antibiotics are not necessarily super helpful one way or another. I think this is where you really want to engage your clinicians and say, is this helpful, right? Is it helpful to treat this? And you always have the option, do not use antibiotics except if it's helpful. And usually, again, in UTIs, it can be really helpful because it can help with the burning. Um, but treating pneumonias at end of life doesn't necessarily really improve quality of life. There's a lot of things that we can do from a symptom management standpoint that can really be helpful. But again, this is where, like, what's the big picture process going on? And are these smaller interventions going to have a long-term big picture effect? I think these are the questions that we need to be asking. And then additional orders, sometimes people have implanted pacemakers and other devices. People have really strong feelings about blood products. This can be added here. And again, the question is that going to make me feel more comfortable? One, is the burden worth the risk or the actual intervention itself? Um, Really eliciting, based on my values and based on what we have talked about, provider, doctor, or other provider, what are your thoughts on me pursuing this? I think it's really important to pull from the provider resource to really help you with answering that. And then questions there?
No questions there. Thanks.
Okay, awesome. And then Sonia, if you want to just scroll to show the rest of it, the rest of the form has all the like practical, important, legally things, like things need to be signed. They want us to document whether somebody has a living will or a power of attorney, and everything needs to be dated. And then the other thing is, depending on the state you're in, it needs to be renewed. It needs to be filled out properly. It needs to be renewed. It also needs to be filled out by somebody who knows how to fill them out, because we want to make sure that the MOST or the POST makes sense, right? You cannot be aggressive on one side and not aggressive on the other, unless it sort of has like a really linear um, process. For example, you cannot have CPR and say that you don't want a tube, because the only way we can secure the airway, meaning we can make sure that we're getting air into your bodies, if we're engaging in a very invasive medical procedure, which is intubation. And so these things are important. We can talk about trials of things, but by and large, things have to kind of have an order to them that makes medical sense procedurally. And so we want to make sure that you are looking at it, download it, take a look at it, read all the blogs and all this stuff that has the information, but make sure you're filling it out with somebody who's done it before. Any other questions here, thoughts?
Not so much. I think you've explained it really well. I think your last point there about kind of the cascading effect of things is really important. 'Cause yeah, I mean, perfect world, you'd be able to choose every little detail, but we have what we have.
We have what we have. It's really well put. Another really important thing to keep in mind is that this document is changeable. It's not written in stone and can never be changed. If for some reason you travel to Portugal and have some holy water and it fixes things, and you tear up the document if it makes sense to you. If you say, you know what, I want it to be full treatment, and now I'm feeling like this fourth line of chemo isn't really doing it for me, and I kind of want to take a step back, you can change it. The key thing is to keep the conversation going with your clinician and make sure that your village, especially your healthcare proxy, is really aware of where your head's at. Um, Another really important thing to say is, in general, a healthcare proxy can't people are really afraid that if I assign this person who loves me and wants me to be alive forever and ever as healthcare proxy, that they'll negate the most and they'll go against the most. In general, a healthcare proxy can help with de-escalation of care, not escalation of care. So if you said, I want a natural death, and for some reason you're no longer able to make a medical decision for yourself, but there's a MOLST, a healthcare proxy cannot come in and say, no, 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 I want you to actually do CPR. However, if you're CPR and a healthcare proxy comes in and says, based on our last conversation or based on what I'm seeing, I believe strongly that doing CPR would not honor my loved one or would not give them the outcome that they want, they can absolutely de-escalate care.
Okay.
And so that's an important thing for a healthcare proxy to know, that they can do what's in the best interest of the patient based on the data they have in front of them. Because like you said so brilliantly, you're not going to be able to prepare for every possible thing.
Hmm. Thank you so much.
Yeah, absolutely. With one last minute, I'd love to just really briefly talk about time-limited trials, if that's okay. For many people who are experiencing serious illness, it's really difficult to make absolute decisions. And so time-limited trials are something that people may exercise if offered by a clinician. What does that mean? It means I'm getting this chemotherapy treatment. I was walking, I was even driving to work, got this really bad pneumonia. And in general, I want to be less aggressive, but the healthcare proxy or folks believe strongly that, there may be this opportunity to treat this and we can do a trial. Or somebody says, actually, this person's dying, but they wanted to give it a week. A time-limited trial may be something to consider. Of course, if somebody's dying, we want to make sure that a conversation is had about what to expect and to be really understanding of holding hope and reality together. But a time-limited trial allows for some treatment and once that time is up, we can reevaluate. And usually at that point, a lot of folks will say, okay, we gave it a college try. Now we can sort of de-escalate, meaning we can take a step back. That can be really hard for some folks, right? We're taking away something, but it can be something that holds and gives comfort to some folks. The important thing is to know that I like to look at it as, you gave it a try and now we're stopping something that is no longer helpful or useful, as opposed to taking something away. So definitely an option for many folks. Questions about
Okay.
that?
Not so much. I think you explained it really well. Yeah.
Awesome. I think we covered a lot. It was very heavy. I just take a deep breath because this is really, really intense stuff. And I think when you reflect on it, you realize how incredibly helpful it is to think about this stuff. And yet it's really taxing because it's also making really big decisions about your life or your
Right.
loved one's life. And so I want to thank you for doing this with me, AJ. I really appreciate it, and Sonia. Um, and yeah, just wish you all the best.
Thank you so much.